So atrial flutter is one of the rapid heart rhythms, and we usually think of it in a family with atrial fibrillation. Both of them have very rapid electrical activity in the little chambers of the heart, and both have the same problem where the little chambers are therefore not squeezing. It's so quick that instead of a squeezing pattern, we have quivering of the little chambers. We see atrial flutter sometimes as the first rhythm problem that people will have. Sometimes we see it in people who have already had atrial fibrillation, and as part of their treatment, the electrical activity is made more regular. That's what separates it from atrial fibrillation, that regularity of the electrical activity, usually as a circuit, and most commonly in the right atrium. But sometimes we see atrial flutter arising many years after some other procedure in the heart. It could be an open heart operation, a mitral valve repair procedure, and then the other situation is after ablation for atrial fibrillation, where the ablation lesions that have been applied in the left atrium create corridors where circuits can set up and new loops arise. Most people who develop atrial flutter, like those with atrial fibrillation, will have a perception of the heart beating quickly. The main difference though is that because the atrial activity is more regular, the conduction to the bottom chamber can also be more regular. So there isn't the perception of higgledy-piggledy beating or like Morse code that people will often describe in the bottom chamber with atrial fibrillation. But other symptoms like being out of breath, fatigue, sometimes lightheadedness, it really can vary. Nowadays, when people are using wearable technology like watch or Fitbit, we can have high heart rate being an initial clue, and there may be no symptoms otherwise, just the high heart rate. One of the things that fascinates us about atrial flutter is how frequently people turn up with exactly 150 beats per minute as their heart rate. That's because the atrial flutter circuit in the right atrium is remarkably consistent across different patients at about 300 beats a minute, and every second beat is conducted to the bottom. So that rate, about 150, is often a clue to us that that might be what we're dealing with. We make the diagnosis of atrial flutter always on an ECG. It has a characteristic appearance. It might be picked up on an ECG that's done in the room or on a Holter study, or now with wearable technology, people will record ECGs that we might see the flutter waves there. Atrial flutter, like atrial fibrillation, has very similar foundations. As people get older, it's more likely to happen, but anything in the heart that increases pressure or stretch on the little chambers can contribute. Leaky valves, hole in heart, high blood pressure, for instance, and previous procedures can also lay the foundations of the rhythm problem coming back years later. In terms of triggers at an instant, it can be things like an infection, surgical procedure, excessive caffeine and alcohol. All of those can be triggers on a particular day, but very often there's nothing in particular. People sometimes ask if atrial flutter is a dangerous rhythm. The short answer is it isn't, but there are consequences we have to be mindful of. The first of those is the risk of clotting and stroke, and if we have someone who's anticoagulated to prevent that, then that risk is largely taken care of. The other concern that we see more with atrial flutter than atrial fibrillation is the problem of very rapid conduction to the bottom chambers of the heart. So if we have a high heart rate that's maintained over a longer period of time, the heart can become weakened. So that's something we want to deal with sooner rather than later. So the issues with managing atrial flutter relate to dealing with the risks of clot and stroke, and also managing the symptoms that people have. And whilst we can treat with medications, you'll find that we'll often very early go down an ablation path, because this rhythm is eminently suitable to a curative treatment that will mean that it is eliminated for the longer term. In terms of the medication treatments for atrial flutter, we will potentially have anti-clotting treatment applied to reduce the risk of a stroke, but we might use medication to slow the conduction of the atrial impulses to the bottom chambers of the heart to control the heart rate. We might use medication to stabilise the rhythm and even prevent it from occurring. The strategy of ablation for atrial flutter is an attractive one because the circuit in most patients will be in the right atrium and it's very accessible. we can achieve very high success rates beyond 90 to 95% for a single procedure, and the patient will have long-term freedom from that rhythm. In addition, we can ablate with very low risks of complications. We're talking about risks less than 1 in 1,000 of anything going wrong. In comparison, treatment of atrial fibrillation with ablation has a little higher risk and the success rates are a little lower. So you'll often see ablation applied earlier in the treatment scheme for flutter than for atrial fibrillation. The strategy of ablation relies on us understanding where the circuit is and creating a barrier to block the circuit. Usually the circuit will be in the right atrium, and our strategy is to come from the groin through the vein up into the heart with a catheter, and we will cauterize a fire break along the floor of the right atrium to interrupt that looping circuit and enable it to be prevented from starting up again. In most cases, an atrial flutter ablation will take somewhere between 30 and 60 minutes. The patient will remain in hospital overnight just to be sure that there are no problems before they go home. Most of our cases these days are done under general anaesthetic, and so people can expect very little discomfort other than where we go through the groin, and there's usually just minor bruising there.